Thank you. So we have another round of applause for all of our panelists. Thank you. That was fantastic, and it's a lot of food for thought. So now I'd like to invite Dr. Burston back up to the stage, and now we'll have an opportunity to ask questions from the audience. I believe there are mics circulating. Do we have them on the tables? Oh, I think there are stand mics. So there's one by the tech table over to everyone's, oh, both sides, sorry. Both sides of the room. So if anyone has a question, feel free to stand at the mic. While folks are queuing up, because I know you're all burning questions, wanted to, because we didn't have a chance to ask questions of Dr. Burston after her talk, just wanted to see if you have some reactions to the reactions and anything surprising that you might have heard from our panelists.
I didn't hear anything surprising. I think it all is consistent. It's especially interesting, though, I think, for us to really understand the different perspectives, the state perspective, the federal perspective, and the employer perspective, and what they each bring to the big policy puzzle, and thinking about that holistically rather than in those narrow corridors, I think is a real challenge for us. So perhaps, you know, from your policy perspective, a real opportunity. What's different, what's the same, and what could get moved forward?
Given that our panelists did not have a chance to ask you questions, I want to encourage any questions of Dr. Burston from our panelists before the audience joins in, or any discussion that you'd like to engage from hearing each other.
It's not a question, and this, a lot of the things as I said in my comments, I tried to directly link to what Helen said, and you know, had similar views. The thing that I hadn't thought about recently was the medical education angle, which I mentioned in passing, and then just immediately headed off. You know, several years ago, MedPAC made recommendations in the medical education space to try and de-link payment to hospital, but you know, the medical education payments on hospital admissions and to the hospital. Admissions to the hospital, and try and make the payment around more the graduate medical education, or the residency program, I'm sorry, the residency program itself, and then try and tie those payments to the aspects of the particular medical residency program. You know, does it emphasize team-based care? Does it drive evidence-based medicine? And of course, at the time, you know, we could have also said, does it have components where you're using telehealth and that type of thing? And it was, instead of having the payment in Medicare just driven by admissions to the teaching hospital, have the teaching payments actually be built around the residency program, and look for particular criteria in the residency program before the money is just dropped on the doorstep of the hospital. One huge complaint being among educators is that money is used to run the hospital. It's not used to educate or to change the residency program. So it's just something I had not thought about for a while, and so.
It's a really interesting piece of this puzzle. There's a lot of money that goes into that space. There are requirements of what are for GME, the ACGME clearly puts forward recommendations of what should be part of training programs. There's always been a component around technology. It's just never been very specific. And so in this new world, people have to understand how you interact in this way most responsibly to get the best possible outcome. So I think it's a real opportunity. And I don't want to be, even though, you know, I now lead an organization of doctors. This is way bigger than doctors alone. This is really about health professions education broadly, whether it's nurses or pharmacists or anyone in that space who's going to be working in a very different environment that isn't always face-to-face.
I think this is on now. Yes. Thank you. I think we have a question from over here.
Hi, yes, my name is Clese Erickson. I'm with George Washington's Health Workforce Research Center. And one of the things we've been looking at is the impact, and I've heard you all talk about, is the impact of telehealth on addressing maldistribution. But I wonder if you could comment and share any evidence that you've seen, whether you think it will reduce overall demand for physician services and other providers, or if it has any potential there, if you've seen any evidence of that to date. And I'll add, the reason I mentioned that is a lot of people, when they're talking about workforce shortages point to telehealth as a way to ameliorate shortages. And that's, I think, more from the maldistribution side of things, but I wonder if there is any potential, if you see it, for reducing just general demand.
Anyone want to jump in? Yeah.
I'd like to talk about the maldistribution and rural health, and I think the rural crisis of getting specialty care to rural areas is an area where telemedicine is starting to play a serious role in bringing more specialty care into rural areas. And so I think the funding crisis in rural health of, do we fund a full-time doctor who really doesn't have full-time volume and can't necessarily keep up with the changes in technology in a rural area? I do actually think that the supply and demand will be helped along with telemedicine and rotations. And this is something that's only possible with electronic medical records, rotations, and telemedicine. And it is beginning to be effectively deployed in rural areas in Maryland, and I know in other parts of the country as well, but definitely we're seeing a deployment in Maryland, and that is reducing some of the losses that rural providers experience when they try to hire a full-time doctor to do a part-time volume of work.
If I could just add on to that, I mean, I'm struggling because it's such a good question, because there's this tension between the convenience versus access set of issues that were raised by my co-panelists, but also there's such a desperate need in rural areas, as I am learning a lot through working with this project, that it's all hands on deck. So I wonder if there's even a third component to this, and that is, do we think less traditionally about how these tele-support services actually might be deployed to people who need, unless it's super specialty services, need for, let's just take behavioral health, for example. There are a lot of things that can be done to improve people's outcomes that don't involve, you know, a PhD in psychology, and I can say that because I am one, but there are other solutions perhaps that can be augmented through tele-options that don't necessarily involve the traditional workforce, and just figuring out how to realign that maldistribution.
Yeah, and I probably just don't have enough of imagination, or, I mean, I definitely think of it as addressing the maldistribution. I definitely feel like sometimes people talk about it as overcoming shortages, and I think sometimes if there's shortages, if you have behavioral health problems, you can telehealth, and it's not necessarily going to overcome those shortages. It may help, and it may help with some distribution. But I haven't had the thought of, oh, well, this will actually reduce demand. I'm more of the mind that at least some of the components of it are likely to increase demand, depending on if I understood what you meant by that particular comment.
And maybe just one last thought, and I agree, it's a really good question that I don't have a good answer to, other than I think we have to start thinking about our workforce analyses differently, right? If you can incorporate in the potential for distance learning or providers off-site, particularly the provider-to-provider side, it may change our models of what we think workforce requirements are in a given area. So it's a really important question. Thank you for asking it.
So I'll just add a little bit of a different angle on this. I think we often hear of how overburdened physicians are, and the opportunity to leverage, whether it's telehealth or retail clinics. If I look at what CVS and Aetna are looking to do with their integration, expanding different access points to primary care that could possibly free physicians up to take on more complicated, challenging issues. So theoretically, you can see where, or conceptually, you can see where that seems to make a lot of sense. Whether or not it's having that type of impact, I don't know. I haven't seen any data on that.
Thank you all. I think we have a next question from the audience.
Hi, good morning. I'm Andrea Shore with the School-Based Health Alliance. My question's for Sandra. I am curious if any of we work with providers across the country who are either working in schools, directly in school-based health centers, or in community health centers who are collaborating with schools. And I'm curious if any of the projects that you're working with have pediatrics as either a large focus or something that you're providing some technical assistance on as it's growing in our field as
Yeah, and it's so important. And unfortunately, the answer is no, not currently. A lot of the focus, as you might imagine, is really around where to make the business case. So we end up focusing a lot on the higher needs individuals, either on the adult end of the spectrum, or if it's children, it's children born to mothers, with addiction and those kinds of things seems to be where a lot of the acute need is, and that the innovations often start there and then spread to the broader system. So we aren't currently, but I'm sure you're familiar with the McPack project, right, with all of those kinds of pediatric interventions that could be used through teleconsultation, telesupport. And I'd love to hear your thoughts about how we can support states more in that area.
Definitely have thoughts.
Thank you. Another question over here?
Hi, I'm a technologist, so that's my disclosure. And I've been to many healthcare tech conferences over the past year and a half. And almost all conversation ended up with the one word reimbursement and fee for service. So it was very obvious very early on that value-based care is perhaps the biggest component. One observation that I wanted to share with you and have people to comment on is I started looking at senior care later this fall, and I found that specifically the architecture of the senior care campus, where you have skilled and assisted living co-located with residential services, their tech adoption is a very interesting phenomenon. They're looking at voice-activated technologies through Alexa, they're trying to integrate that with EHRs at the back end. Their openness to robotics, their openness to remote patient monitoring for wellness perhaps, and then also for more clinical things. And the fact that you have a population where you have the assisted care facilities or the skilled nursing facilities where you're getting care and you just move off literally across the street into your own home, and the remote patient monitoring can still track you in a close proximity. So when I think about the POCs that are happening in other settings, it seems like this might be an interesting setting to kind of expand on and invest time and effort in. So I just wanted to hear if you had considered that setting. There are about 2,000 of these, what they call now life plan communities, with about more than 500,000 units, which is about, I would say 1 million people today. But they're growing fast, and they have implications on home health care as well, because a lot of these senior care facilities are now getting licenses to operate in the community, and they want to extend their services there. So I just wanted to hear if you've considered this.
So there's a couple of differentiations I would make. So and this, whether this is right or wrong, this is a fact. I mean, there's a stage in an elderly person's progression in which Medicare becomes much more involved, but the assisted living facility platform itself, and to the extent that it's a continuous care, non-acute nursing situation, Medicare actually doesn't play in that particular environment. Where Medicare plays is home health, and home health is usually defined as a homebound situation. Although I would argue, to the extent that the provider takes risk, that requirement could and should be relieved. Or Medicare plays when the person has an acute skilled nursing visit, which may be a component of what you're talking about, but not necessarily the day-to-day maintenance of care. And to the extent that the person is, and actually people in those communities are not as likely to be Medicaid eligible would be my guess. But the kind of maintenance level of nursing care really gets driven on the Medicaid side, and then you have these two large federal programs that are trying to interact with each other, and there's a whole history of difficulty in trying to coordinate, which I'd like to blame on Sandra. She's sitting right here. So the notion of it is very logical to say, I'm looking at this population, we should be thinking about it, and it's a perfectly reasonable thing to do. But I think to the extent that that person in Medicare is more of a managed care environment or in an environment where their total cost of care is being managed like in an accountable care organization, ideas like that have a lot more traction. If that person is just kind of in Wild West fee-for-service, I think it becomes a bit more difficult to think about it in a comprehensive way. And about 2/3 of the Medicare beneficiaries are still on the fee-for-service side.
I'll just add, I think there's an opportunity as we think about moving towards more and more of population-based payment, particularly for populations at risk, to just think very differently about what kind of outcomes you would assess and pay on. So you could easily see a model that's focused, for example, on the multiply chronically comorbidly ill elderly, in which payment can differentiate, regardless of how the services are provided, what are those long-term outcomes, what are the functional outcomes, what is the prevention of the high-ticket items like ED visits and hospitalizations, and then allow that innovation that you're providing to just be part of what you can negotiate with those settings, because they know at the end if they do well on those big functional outcomes or utilization outcomes, they'll do well.
Thank you. We have another question.
Hi, I'm Rob Saunders from the Margolis Center for Health Policy at Duke, and I wanted to follow up actually on the sort of reimbursement payment question. So we do a lot of research looking at new payment models and trying to see what evidence is out there. And one of the struggles we see is that for many organizations, when they enter into an ACO or a bundle arrangement, we've removed a barrier that may have stopped them from, say, using telehealth, but that doesn't necessarily get them over the hump to trying something new, because they may not know how to use the technology, they may not even know where to start with buying the infrastructure, and there's a sort of operational guidance that they're still lacking that sort of comes along with the payment model. The payment model raises awareness, but then you still need to do something in order to succeed under that payment model. And I wonder from the panel if there's been some thought from any of you on how you sort of make that transition and supporting the health systems as they're trying these new value-based payment arrangements while they are trying to try out these new ideas in telehealth.
You didn't say this, and you're still standing there so you can defend yourself and all the rest of it, and you should. But and I will try and answer your question directly, but I just want to say one other thing before I do it. And you didn't say this, just to be clear. This is usually how the argument goes. People come in and they say, well, often they don't want to accept the new payment system, but let's say they do. There is this new payment system, ACO, I'm willing to take risk, whatever the case may be. But now here's what I need. I have to make an initial investment. You need to pay for that. You have to train me to do it. You need to pay for, explain, give me technical assistance. And then pretty soon, the cost benefit of, well, if this was going to yield some benefit, to that provider under either an ACO benchmark or a capitated, starts to disappear because the money has been, in this investment or in this training. So I think the question you're asking is really fair and really difficult, but it also raises this question: where is Medicare's responsibility? Should it set the payment and say, as many people are saying, the market will respond, providers will respond, and it's always, will they? And I think it's true. Some of them will. And then some of them will have to be brought along, and how much investment should the government take on that? And then if they take it on, does in fact on net this come out better for the taxpayer or worse for the taxpayer? And I think that's the trade-off embedded in your question. And I always wonder why, if the ROI is as strong as many people say it is, why aren't consultants and others entering this environment and going, you're going to save $1 gazillion, you give me a little bit of those gazillion and I'll help you get it off of the ground. But I think it triggers a key question: how does Medicare or in whatever program, Medicaid, how much do you pay in bringing the person along? Now, I will say one last thing, and we did do some thinking about this. The way, back in my old job, the way the quality support payments occur, like in the QIO environment, we have some, or MedPAC, had some very strong views about how to allocate that money more directly to providers to solve specific problems, as opposed to the current mechanism that's used. It's more detailed than this exchange, but it is a pot of money that could be repurposed for things like this. And I could talk to you offline about that if you're still interested in these comments.
Maybe just one thing to add, and not so much on the reimbursement side, but I think we oftentimes talk about a new technology, a new treatment, and we don't often spend as much time talking about how to implement it as we do what we think it will be. And so there are examples of people who have implemented it, and the U.S. unfortunately still tends to be these incredible islands of innovation and very little bridges across them. And so I think as a community, we really need to think about how we share those best practices, share those implementation lessons, whether it's with or without consultants. What have you done to get your clinicians engaged? What have you done, especially societies, to help bring your members along, to help them say, I want to bring this into my practice. What are the 5 things I need to prepare for in the next year to have that move forward?
And I would just add something you already know, which may be less sexy, but there's this whole dissemination, right, literature that you got to have your champion, it's got to come from the top, accountability metrics that are transparent and public and shared, where you can show this provider is doing an excellent job in this domain that we're measuring, someone else isn't, and fostering that friendly competition, those kinds of things, at least on some of the state initiatives, seem to really allow the delivery and payment strategies to actually take hold and be implemented. That's what we're observing.
I don't think you can look at telehealth in isolation. If you're an ACO and you're taking on risk, to be in a position to take on risk, you need to have other competencies in place within your organization that all come together, whether it's around your care coordination model, whether it's your technology capability and ability to provide analytics to your providers, whether it's around your governance model and whether it's physician-driven or not. There's a lot of different competencies that create a tipping point for a delivery system to be in a position to take on risk. And to look at telehealth in isolation, how do I implement on telehealth? All those other things have to be there if you're going to take risk anyways. And hopefully you can find a way to integrate it into that model. And from an employer perspective, we don't have a lot of sympathy for a delivery system that wants to be paid more to take and to implement some of these initiatives when there's so much waste in the system and there's so much opportunity if you're taking on two-sided risk to win if you can execute. So I think that it's part of the investment. If a company is making an investment outside of healthcare to make their organization more efficient, to launch a new product, why can't we do that in healthcare as well? Why isn't the delivery system in a position to be able to make investments, recognizing there will be a return if they drive the right efficiencies within their model?
He said that better than me.
No, I wanted to comment as well. In Maryland, our system started out before the 2014 experiment with 10 rural hospitals, and they formed a collaborative to work on this together, and to take a provider leadership in this. And also, I think some of the providers in Maryland have stolen shamelessly from some of the Kaiser Permanente ideas. So, for example, Kaiser using a lot of technology admits 80% of their patients directly without passing through an emergency room. And some of our primary care collaboratives have instituted that model and are using a series of technology and communications to admit directly to the floors instead of through the ERs. And so these are copies shamelessly where you can find better practices that can work and really try to drive the provider initiative. And I do think it is difficult because a lot of the providers do tend to say, well, now you gave us this, now tell us how to do it, but then that's not really provider-led innovation. So we really are looking to the providers to lead the innovation, and so that's some of the experience that we've had in Maryland.
Thank you all for responding. I think we have time for one more question.
Thank you. Good morning. I'm Margot Edmonds from Academy Health, and I have a continuation question to what Rob started with the panel, and it's particularly for Helen and Mark. And my question is about what are the policy levers to get more team-based care besides payment? And Helen, you alluded to the role of professional societies, and I think you're uniquely positioned to talk about that, but my concern is what we live through with meaningful use in EHRs and the informatics community and the real separation between clinical training and hands-on technical training. So what are some of the other levers that we can use besides just payment, particularly in the professional communities, to train people not only to feel comfortable with the technology, the clinicians and the highly credentialed clinicians, but also to train in teams where there's more lateral decision-making that's shared, which is a real culture change?
That's a great question, Margot, who I had the pleasure of spending the day with yesterday on the Academy Health Board. I think there are some real opportunities that go beyond reimbursement. I think some of this gets back to the sense that there's not much joy in practice at the moment. And so can you think about team-based models where really being able to rely on each other and use people's skills to their fullest potentially allow for more effective interactions, a more collegial environment, not this is your job versus my job, but some of the things we've talked about for so many years in primary care and PCMHs and others of, are you sitting next to your medical assistant? Are you getting their input in a different kind of way? And I think the question will be, and I'd love to hear Mark's perspective and others on this, currently we're still stuck in this environment where physician payment is physician payment, and a lot of it is specifically related to the individual work of that physician. So, I get paid depending on the rates of my screening tests that I provide in an office setting. Again, it's that individual physician level performance. I think as the system moves away, hopefully, from individual physician level payment, it begins to think across more bundles and system level payment. I think it allows more of that flexibility, but then I think it gets back to the training piece as well. I think we need to do a much better job of training health professionals together to fully respect and understand what we each bring to the table.
We out of time yet?
You have another minute, Mark.
Actually, kind of a hard question for me. But what I would say is, like, you said other than payment, but, you heard my talk, you heard everything I've said since then. It's like that's going to matter a lot, okay? I also think, and Helen and I have had some of these conversations, and I can't remember how close she is to me on this, and she may not be, and reasonable people can disagree. I also think to the extent that we move our quality measurement out of like micro process, I did this, my aspirin after heart attack, therefore I'm done, that type of thing, and more to population-based measures, and say, I'm looking for the patient not to go to the emergency room, I'm looking for the patient not to go to the hospital, I'm looking for the patient not to die, those types of things, and then be more agnostic about how systems of providers get to that goal, which may force more collaboration and discussion across boundaries, is something that the Medicare program could do. Because I see this constant tension of trying to set a roadmap through dollars and measurement, but not going below that and micromanage underneath it. And yet, from the the provider community, you get very mixed signals. It's like, don't tell me what to do, but measure everything I do and move the money on that basis. And by the way, you didn't do it accurately, and I don't agree with those measures. And it's like, how, from a policy perspective, and I'm being somewhat glib, maybe even a lot of glib, but, you know, how, from a policy perspective, you know, a big government, you know, nearly $700 billion program, do you square those signals? And my view is you get up to the top, you try and make payments across providers and try and measure across providers, and then leave flexibility to the providers to figure it out, their professionalism, that type of thing. And then I will say again, I know I said it now the third time, I do think education at the front end when people matters a lot.
Yeah.
Just add one quick thing, just because we're not just on the payment side. And I will say there are two things, again, I'm coming from the behavioral health world and speaking, you know, with my provider hat on, former provider, and talking with providers. And I would say there are two things that often drive it. And one is need for relief, desperate need for relief, and exposure. So the need for relief, meaning we don't know what our path forward is, and if we don't figure out how to get all hands on deck to solve this problem, really often drives multidisciplinary solutions, and therefore is an impetus for a legitimate team-based approach. And what is the answer to that on a policy level? I don't know, but let's study it and figure out, you know, what can states and federal government do to support more of that. And then I would say the exposure piece is based on a visit I had to Montefiore, where we talked with pediatricians who said it wasn't until we got the behavioral health people in the room where we actually started to ask people if they had any mental health concerns, right? Because we finally knew we could give it to someone else. We were afraid to ask because we couldn't solve the problem. Now that we have exposure and we know we can trust these people to help solve the problem, we're starting to do it. And I would say those two things are really driving it in a non-payment way.
And unfortunately, that needs to be our last word. We are at time, and so I'd like to thank our panelists. It's been wonderful. Thank you all so much for starting off our day with such a tremendous discussion.